Welcome back to the deep dive. Today we took your source material and we really jumped into a topic that can feel pretty overwhelming: the pharmacology of pain, spasticity, and inflammation.
It's a huge area. I mean, you look at the list of drugs and the terminology, it's easy to get lost.
Exactly. So this deep dive is really for you, the learner. Our mission isn't just to list facts, it's to pull out the high stakes knowledge.
The stuff that really truly matters. We're thinking about it in terms of, traffic lights.
The traffic light system, I like that.
Yeah.
So for every drug, we need to know the green light, what's it for?
Right. Then the red light, what is the biggest, most serious danger?
And the yellow light, the caution sign. What's the one thing you absolutely have to monitor?
We're going to hit the big groups, muscle relaxants, the whole opioid system, which is a fascinating push and pull. And then, of course, the non-opioids, Tylenol, NSAIDs, even steroids and migraine meds.
Okay, let's start with the drugs that manage that physical tightness. The muscle relaxants. What's their basic job description?
So their one job is to reduce skeletal muscle spasms or spasticity. They work either on the muscle directly or, more often, on the central nervous system.
And the key thing to remember here.
They do not touch opioid receptors. This is so important. They are a completely separate class of drug.
Okay, let's break this down with a few key examples. First up, baclofen. You might see that baclofen ending. This is for more chronic conditions, right? Like MS or a spinal cord injury.
Exactly. That's the green light relief from chronic tightness. And the side effects are what you'd expect from a CNS depressant: drowsiness, some weakness, dizziness.
Which immediately flags that yellow light, that monitoring point.
It has to be fall precautions, especially when someone is just starting the medication.
But the red light for baclofen is, well, it's not what you'd think. It's not about taking too much, it's about stopping.
No, not at all. This is the critical takeaway. The danger is stopping it abruptly.
Why is that?
Think of it like a giant brake pedal on the nervous system. If you just yank your foot off that brake, the whole system can go into what we call rebound hyperexcitability.
Which looks like?
Seizures, hallucinations. It's a severe, dangerous withdrawal. The absolute rule is you never, ever stop this medication suddenly. It has to be tapered.
Wow. Okay, so managing the withdrawal is just as critical as the dose itself. Next up, dantrolene, the Rolin. Also for severe spasms, but it has a very unique, very high-stakes second job.
It does. Dantrolene is our go-to for malignant hyperthermia.
That rare but deadly reaction to anesthesia.
Yes, the one that causes muscle rigidity and a super high fever. It's a lifesaver in that very specific scenario.
So a high-stakes drug, what's the internal risk, the red light?
It's the liver. Liver toxicity is the major concern. So the yellow light, the monitoring point, is non-negotiable. You have to watch the liver function tests, the LFTs.
And if you see signs?
Things like jaundice, that yellowing skin, or even just unusually dark urine, that needs to be reported immediately. With dantrolene, the liver is always priority number one.
And rounding out this group, we have cyclobenzaprine, a pocillocrin drug. This is more for acute stuff, like you pull your back.
Right, a bad back strain, neck pain. The side effects are pretty significant, though. Drowsiness, very dry mouth, sometimes confusion. These are called anticholinergic effects.
And that's a huge problem in older patients.
A huge problem. You give this to an 85-year-old, and that confusion can look just like a sudden slide into dementia. It dramatically increases their fall risk.
So the safety rule is?
Avoid alcohol completely and use extreme caution in the elderly. The fall risk is just too high.
Okay, that's a great baseline for muscle management. Let's shift to a system with probably the highest immediate risk: the opioid system.
This system is all about a dynamic tension, a push and a pull.
On one side, you've got the agonists. They relieve pain by activating the opioid receptor.
Right. They turn the pain signal down.
And on the other side, the antagonists, which do the opposite. They block those receptors.
They're the reversal agent. Let's look at the classic agonist first. Morphine, a plight-gagenfang drug. For severe pain, post-op cancer pain. It works.
But the red light is massive.
It's singular and it's life-threatening. Respiratory depression.
Why does a painkiller stop you from breathing?
Well, those opioid receptors are packed into the parts of the brain that control automatic functions. Breathing is one of them. You activate those receptors too much, and you suppress the body's natural drive to take a breath.
So the non-negotiable monitoring point, the yellow light, has to be?
Respiratory rate and OSAT, always.
And the sources give a hard rule. Hold the dose if the respiratory rate is less than 12. Why 12?
Below 12 breaths a minute, you're in the danger zone. Breathing is just too slow, too shallow to get enough oxygen into the blood. The risk just outweighs the benefit at that point.
Which means you always have to have what on hand?
Naloxone, Narcan, it has to be ready to go, no exceptions.
Which takes us right to the other side of the coin. Naloxone, the Oxone drug, the crisis reversal agent.
It saves lives. But you have to understand, it is not a gentle process. The side effects are basically instant severe withdrawal.
The pain comes rushing back.
All of it, plus agitation, vomiting, it's rough. But the patient is breathing.
And the key safety priority here, beyond just giving the drug, is something more complex.
It's the half-life. This is so important. Naloxone has a much shorter half-life than the opioid it's reversing.
Meaning, it wears off faster.
Much faster. It might be gone in 30 or 60 minutes, but that morphine is still in the patient's system.
So you could reverse the overdose, walk away, and the patient could just slip right back into respiratory depression.
Exactly. So the essential management is being prepared for repeat doses. The first shot is just step one. You have to keep observing.
That's a critical point.
Hmm?
Okay, let's switch gears to the drugs many people see as milder, but they carry their own big risks. The non-opioids.
And the first distinction we have to make, it's absolutely crucial, is acetaminophen versus the NSAIDs. They sit next to each other on the shelf, but they're completely different.
Let's start with acetaminophen, Tylenol, that pseudonym ending. It's for mild pain and fever. But what does it not do?
It has zero anti-inflammatory effect. None. It helps with pain perception in the brain and fever, but it will not reduce swelling.
And it's red light. It's major danger.
Is the liver. It's incredibly toxic to the liver in high doses.
So the management priority is all about that dose limit.
It is. The absolute max is 4,000 milligrams a day. And you have to be so careful because it's hidden in everything. Cold medicines, flu remedies. It's easy to accidentally overdose.
Now let's contrast that with the NSAIDs, ibuprofen, aspirin, celecoxib, the DL-profen and DL-coxib drugs.
These are your triple threats. They do pain, they do fever, and they do inflammation.
But their mechanism is also their downfall.
It is. They work by blocking prostaglandins. The problem is, prostaglandins also protect your stomach lining and help your kidneys function.
So when you block them, the red light isn't the liver anymore.
No. Now the risk shifts to the GI tract bleeding, ulcers, and the kidneys. Kidney injury is a major risk with long-term use.
So the yellow light, the monitoring, what's the immediate instruction?
Two things. One, always take them with food. It helps buffer the stomach. And two, you have to monitor for signs of a GI bleed black, tarry stools, new fatigue, and you have to watch renal function. Kidneys and stomach. That's the NSAID mantra.
Perfect. Okay, let's use our last few minutes on some specialized treatments, starting with migraines.
We're talking about the triptans here. Sumatriptan is the classic example. The triptan.
Its job is stopping a migraine in its tracks, and the way it works is the key to its risk.
Exactly. Its mechanism is vasoconstriction.
It narrows the blood vessels.
It does. In a migraine, blood vessels in the brain can dilate. The triptan constricts them, which relieves the pressure. But that means you feel it elsewhere. Chest tightness, tingling, dizziness.
I can see the risk. You're squeezing blood vessels all over the body.
Precisely. Which is why the essential safety check is a cardiac history. You absolutely cannot use these in someone with uncontrolled high blood pressure or heart disease. The risk is just too great.
Next up, the heavy hitters for inflammation. Glucocorticoids. Prednisone, hydrocortisone, the flucosone drugs.
These are powerful immune suppressants. So their first red light is an increased risk of infection.
Makes sense.
But they also wreak havoc on your metabolism. The other major side effect is hyperglycemia, high blood sugar.
And just like baclofen, there's a big rule about stopping them.
Yes, a huge rule. Your body's adrenal glands stop making natural cortisol when you're on these. If you stop the drug suddenly, your body has no cortisol, and that can lead to a fatal adrenal crisis.
So just like baclofen, you never stop abruptly.
Never. You have to taper. And the yellow light is monitoring blood glucose levels very, very closely.
Okay, last one. A quick distinction between the two types of antihistamine.
You've got the first generation, like diphenhydramine or Benadryl, the anamine ending, works great for allergies.
Good.
But it causes major drowsiness and dry mouth. So the safety priority is, once again, high fall risk, especially in the elderly, and you have to avoid alcohol.
Compared to the newer ones.
The second generation, loratadine, cetirizine. The adenine and cetirizine. These are your non-drowsy options.
Why are they non-drowsy?
They're designed differently. They don't cross the blood-brain barrier as easily, so they don't cause that central sedation. They're much safer for daytime use, for driving, for just being alert.
This has been just a fantastic tour of the safety fences here. We've really mapped them out.
We have. We know to watch the liver with Tylenol and Bantroline. We know to protect the kidneys and the gut with NSAIDs.
Hmm.
And most importantly, we know to keep a constant watch on the respiratory system with morphine.
So for you, the learner, it all comes down to this. Knowing the drug's name is maybe half the battle.
Maybe. True mastery is knowing what that drug demands from you, what you have to watch for, where those red lights are.
Which brings us to our final thought for you to take away from this deep dive. When you look at the opioid system, you see this incredible tension. The most powerful pain relief we have, morphine, carries the most immediate, life-threatening risk respiratory depression.
And it requires us to keep its exact opposite, its antidote, naloxone, right there at the ready.
So the question to mull over is this. How does that fundamental pharmacological tension, where the strongest relief carries the most critical danger, how does that shape our entire societal approach to defining, managing, and even judging human suffering? We'll leave you with that.